In this video, we'll discuss about needle stick injury management. It having 6 main important steps. Stepwise management of needle stick injury, exposure and sources code, then post-exposure prophylaxis, then laboratory investigation, then follow-up. So first step we want to discuss management of exposure site, first aid. So the first step to be taken in case of a needle stick injury is to manage the exposure site. Exposure site. First, don't panic. If the skin is pressed by a needle stick, okay, if the skin is pressed by needle stick or a sharp instrument or object, immediately wash the punctured site. Okay, so when we have needle stick injury, immediately wash the punctured site and surrounding skin with water and ordinary soap thoroughly. Don't scrub or squeeze the wound. So by using soap and water, we wash thoroughly. Don't scrub or squeeze the wound. Then don't use antiseptic or skin wash. Don't use bleach, chlorine, alcohol, betadine. So don't use bleach, chlorine, alcohol and betadine. Don't put that pricked or cut finger in the mouth in a reflex action. Don't put in the mouth in a reflex action. The first dose of post-exposure prophylaxis PEP, post-exposure prophylaxis should be initiated within 2 hours of exposure for the benefit of laboratory staff working outside the routine hospital hours. First dose of post-exposure prophylaxis, that is PEP, should be initiated within 2 hours of exposure for the benefit of laboratory staff working outside the routine hospital hours, like the evening shift or an emergency night duty. The first dose must preferably be available in that laboratory. So, like evening shift or emergency night duty, the first dose must be preferably available in the laboratory itself, so that the PEP, post exposure prophylaxis, can initiated within 2 hours instead of delaying it until the next morning. Following the first aid, the step 2, report the exposure to that immediate supervisors. So report that exposure to that immediate supervisor. Next, consult the physician of that institution. Next, consult physician of the institution who has been designated to address incident of that exposure to the healthcare worker. So next, consult the physician of that institution who has been designated to address incident of the exposure to the healthcare worker. Then who will then review the incident and assess the eligibility of exposure healthcare worker for post exposure prophylaxis, the need for PEP against HIV will depend on the exposure itself and HIV status of the source. If the source has been confirmed as positive, it's decided based on exposure code and source code, while the need for against HBV will depend on the vaccination status and anti-HBs level of the exposed healthcare worker. So this one, who will then review the incident and assess the eligibility of the exposure healthcare worker for PEP. The need for PEP against HIV will depend on the exposure itself and HIV status of the source. If the source has been confirmed as positive, it's decided based on exposure code and source code, while the need for against HBV will depend on the vaccination status and anti-HBs level of the exposure healthcare worker. First, understand exposure code. Exposure code categorized mild, moderate, and severe. Mild, moderate, and severe. Coded as EC1, EC2, and EC3 respectively. EC1 referred, for example, this one, exposure to mucous membrane or non-intact skin with a small volume or for short duration. For example, superficial wound or erosion of that epidermis caused by low caliber or small bore needle or splash on the conjunctival or nasal mucosa membrane. Moderate exposure, which is rougher exposure to mucous membrane or non-intact skin with a large volume or long duration, or percutaneous superficial exposure with a solid needle. Third one is super exposure, which is rougher percutaneous exposure with a large volume, large bore needle. Probably more than 18 case, which is visibly contaminated with blood or T punctured with material has previously been used intravenously or intraarterially. So third one is severe exposure, which is rougher percutaneous exposure with a large volume, large bore needle visibly contaminated with blood or T punctured with material that has previously been used intravenously or intraarterially, thereby leading to contact with a significant volume of blood. Next, let us look at source code. A source is the patient on whom the needle was used prior to the accidental prick to the healthcare worker. So, a source is the patient on whom the needle was used prior to the accidental prick to the healthcare worker. Now, the source patient would be HIV negative, in which case he or she should be tested for other bloodborne viruses such as hepatitis B and C virus if the source HIV positive but clinically asymptomatic with high CD4 T cell, asymptomatic with high CD4 cell. So HIV positive, clinically asymptomatic with high CD4 cell, T cell count and low viral load. He or she categorized as low risk or SC1. In HIV positive, clinically symptomatic, low CD4 T cell count, high viral load. He or she categorized high risk, source code 2 or SC2. An instance where an unattended needle or improper disposal needle has caused the prick, probably during management of biomedical waste by the housekeeping staff. It might be impossible to trace and identify the source of patient. In such cases, the status of the patient will remain unknown and neither the patient nor his or her blood will be available for testing. The National National AIDS Control Organization provide guidelines on giving PEP for HIV based on their exposure of source code. PEP is not warranted for the person who have a mild exposure from a source. They have mild exposure from the source who is HIV positive, clinically asymptomatic with a high CD4 count and low viral load. However, it is recommended for person who had mild exposure but from a source who's HIV positive with clinical symptoms, a low CD4 count and high viral load. It is also recommended for person with moderate and severe exposure, that is with exposure code 2 and 3. CD4 count and high viral load. It is also recommended for person with moderate and severe exposure, that is with exposure code 2 and 3. And when the source is HIV infected, irrespective of the viral load level, that is both for source code 1 and 2. If the source is unknown, consider giving PEP if the HIV prevalence is high in the given population based on the risk categorization. PEP for HIV is given for 28 days. It is important to complete the full course on PEP. As mentioned earlier, the eligibility for PEP for hepatitis B depends on the vaccination status and antibody level of the exposed healthcare worker. If the exposed person was unvaccinated, then administer hepatitis B virus immunoglobulin within 48 hour exposure. Hepatitis B vaccine, which consists of 3 doses given at 0, 1st and 6th month. If the exposed person was vaccinated and their antibody titer level was greater than 10 million international unit per ml, no specific PEP need to be given. The individual only need to be reassured. If the person was vaccinated but that antibody titer less than 10 million international unit per ml, administer the hepatitis B immunoglobulin and one dose of HBV vaccine and plan to revaccinate as seen necessary. If exposed person was not vaccinated, anti-HBs level not known. That person not known their antibody level, test for anti-HBs level and take appropriate recommended action. If the person exposed person was previously infected, now HBV that virus carrier, now hepatitis B virus carrier, counsel the individual, no specific PEP. So this one exposed person status and recommended action. Unvaccinated means HBV immunoglobulin within 48 hours. Vaccinated, HBs level more than 10 million international unit per ml means no specific PEP but reassure the individual. Vaccinated but anti-HBs level less than 10 million international unit. So here administer HBV immunoglobulin, then one dose of HBV vaccine and plan to revaccinate. That anti-HBs level not known means test for anti-HBs level, take appropriate recommended action. There are carrier means no specific PEP, counsel the individual. The third step is management is counseling. This is particularly important when PEP for HIV is given. The exposed person should receive appropriate information about PEP and its risk and benefits. They should understand detail of window period, baseline, test, drugs that are used, their safety and efficacy. They should counseled on safe sexual practice till both baseline and third month HIV test are found to be negative. Then psychological support, special leave for work if required should be considered for a period of time, example 2 weeks initially. Fourth step, prescribing PEP for HIV. It is most effective if initiated within 2 hours of exposure. This is the golden time period. There is only minimal benefit if more than 72 are lapsed since the exposure. However, if a healthcare worker reports the incident and present more than greater than 72 hours after the exposure, if the healthcare worker report the incident and present greater than 72 hours of exposure, he or she must still be initiated on PEP. PEP is given for 4 weeks or 28 days. Later, if the risk is found to be insignificant, that is, the source was traced and was found to be HIV positive, or source code 1, then PEP would be discontinued if it is already started. Next, PEP for HBV include hepatitis B virus, immunoglobulin, and HPV vaccine. Following exposure from HCV infected source, no specific PEP, no vaccine available for HCV. Only HB virus only vaccine is available, immunoglobulin and HBV vaccine, not for C. Step number 5, laboratory evaluation. It is recommended to assess the baseline serostatus of the exposed healthcare worker by testing for HIV, HPV, and HCV. Within 6 days of the accidental exposure is recommended. Positive HIV status, discontinue PEP. Discontinue as the person need to be referred ERT center to be initiated an appropriate ERT regimen. Please reminder the period to the testing for HIV and informed contact must be obtained from the exposed healthcare worker. Next, laboratory investigation, baseline investigation. The parameter tested for the baseline investigation: HIV antibodies, HCV antibodies, anti-HBs antibodies, complete blood count, liver function test. Next, step number 6, follow-up of exposed person. At 2 weeks and 4 weeks after exposure, complete blood count, HIV antibodies, HCV RNA is tested. At 12th week, 3rd month, HIV antibodies, HCV antibodies, liver function test are repeated. At 24th week, 6th month, HIV antibodies, HCV antibodies, and liver function test are repeated. In this video, needle stick injury management is discussed. First one is stepwise management, exposure and source code, then post exposure prophylaxis, laboratory investigation and follow-up. Do not panic. Don't use antiseptic, don't bleach. First dose of PEP within 2 hours. Exposure code: mild exposure EC1, moderate exposure EC2, severe exposure EC3. Then source code: HIV negative, low risk SC1, high risk is SC2 unknown. Then eligibility for PEP for HBV. Laboratory investigation. In this one, risk as associated with bloodborne viruses, then preventive measures, overall management, and first aid exposure, including first aid exposure we discussed. Thanks for watching.